Hello, welcome back to my random lecturing. If you've already read or listened to the respiratory lecture, you know I'm a little bit flighty, but thanks for sticking around. This is cardiac disorders. I am a cardiac ICU nurse for children. I've been doing that for the past 10 years, so I am all about the heart. So I'll try to keep this short and sweet and not go too in depth. Because NCLEX doesn't really ask too many questions except for things about 12 leads or EKGs, just like how you can tell a MI in an adult patient. They ask about the difference between acyanotic and cyanotic defects, which we'll talk about. There might be a question about Kawasaki's disease. And we'll touch on hyperlipidemia and hypertension, which are becoming new concepts with the growing trend of obesity. So most of these slides are out of Wong's pediatric books, which are pretty notorious in the pediatric world. Wong makes the best peds books. And then I have pictures that I've placed in there, the little cartoons, which are from the Memory Notebook of Nursing, from the Nursing Education Consultants, which is a really fun group of cartoons. I also use Straight A's in Pediatric Nursing, which is a Lippincott book, which is very nice. And then if you're interested in getting something to supplement to study for NCLEX, I would use Child Health Nursing, Reviews and Rationales, which is by Prentice Hall. And if you want to download something to your iPod or MP3 player, you can go to vangonotes.com and download lectures from there, which is pretty handy. So here we go. By now, through A&P and Adult Med Surg, you should be really familiar with the structures of the heart and also the flow of blood through the heart. It's composed of 4 chambers, 2 atria, which are on top, and 2 ventricles, which are on the bottom. Inside of that are your 4 valves. Your pulmonic valve is your right ventricle to the pulmonary artery, so that's aptly named. From the right atria to the right ventricle is a tricuspid valve. And then on your left side, from your left ventricle out your aorta is the aptly named aortic valve. And then from the left atria down to the left ventricle is your mitral valve, which used to be called a bicuspid valve. But we call it a mitral valve now, more commonly. I mean, it can be known for both ways. So you should know that veins bring blood back to the heart and arteries take it away. So if you have blood coming from the body, it's going to come through 2 major veins and that to return to the heart, and that's the inferior vena cava and the superior vena cava. That'll drop into the right atrium, and then from that it'll go through that tricuspid valve down into the right ventricle. The ventricles are the stronger part of the heart. Through this right ventricle, out the pulmonary valve into the pulmonary artery, which heads to the lungs. Lungs, it goes down into those capillary beds, it exchanges the gases, and then it needs to come back. So it'll return to the left side of the heart, the left atrium, through pulmonary veins, because veins come back to the heart. Even though this is oxygenated blood, it's coming back to the heart through pulmonary veins. And then from the left atrium down to the left ventricle through the mitral valve, and then out the aortic valve into the aorta from that left ventricle back into the body where it gets used up and circulated and dirtied, and then it needs to come back to the right side of the heart through the inferior and superior vena cava. So it's super important to learn this. It's not too complicated. I know it trips up a lot of nursing students, but it's super important to know this because if you know this, then learning any of these congenital heart defects is super easy. So we'll talk about fetal circulation, which is obviously different from the circulation of a baby after it is born. When the fetus is inside the mom, it's in that amniotic sac surrounded by fluid, so it's unable to breathe oxygen. So all of the oxygenation happens through the umbilical cord from mom. So that's attached to the placenta. So the placenta supplies the fetal oxygen. About 90% of blood bypasses lungs through the foramen ovale and the ductus arteriosus. So, I mean, you know, the kids aren't breathing oxygen. The lungs are actually kind of full of a little bit of fluid, which is one of the reasons a vaginal birth is kind of important, because that squeeze of the chest cavity of the baby being born helps expel some of that fluid. Not to say that that still won't happen with a cesarean birth, but it's a little bit more challenging to get a lot of that fluid expelled. So anyhow, the placenta is responsible for the oxygenation through those two ducts, and all oxygen, everything bypasses the lungs, so we're not using the lungs when we're inside the mom. And then inside mom, right side of the fetal heart has a higher pressure than the left. This changes immediately after we're born. The left side has the higher pressure because now the left side is pumping this oxygenated blood to the whole body. And so the left side becomes the very, very strong side, especially that left ventricle, the left bottom portion that has to pump out through the aorta. That becomes a very, very strong side of the heart. So there are two major differences in the fetal circulation, or the fetal heart, versus a born child's heart. The first is the foramen ovale, which is a little hole in between the two atria up at the top of the heart, similar to an ASD, or an atrial septal defect. That's a defect that we'll talk about in a little bit. The foramen ovale is supposed to close at birth, and it closes because the baby breathes, and then now all of a sudden we're using the lungs, and the body needs to supply itself with oxygenated blood through that left side. So the left ventricle and the left side of the heart becomes stronger than the right side of the heart, so then that little hole closes, that foramen ovale. This happens pretty much immediately. The body recognizes that it's not needed, and then it closes within the first few days to weeks. And then the second structure that is there that should close is the ductus arteriosus. And this is a tiny little fistula, or kind of a tunnel between the aorta and the pulmonary artery. And basically it allows for the mixing of blood. We're not necessarily using the pulmonary arteries whenever we are inside the mom or a fetus, because we're not needing to deliver blood to the lungs. So the lungs that go through the pulmonary arteries, the blood that goes through the pulmonary arteries, instead of being delivered to the lung, goes just straight out into the aorta anyway. So this ductus arteriosus closes because the body recognizes that we're breathing oxygen whenever we get our first breath, and it should close fairly soon after. Sometimes we end up having a PDA, or a patent ductus arteriosus, that we have to give medications to close. But otherwise it closes on its own, and it turns into almost kind of a ligament. So both of these changes occur whenever the baby gets good amounts of breaths or oxygenation at the time of birth. So if there's some sort of respiratory compromise, or some sort of oxygenation compromise, these things can be affected. So here's just a picture of the fetal heart and fetal circulation, and I'll just review that over again. We'll start, you notice down there in the liver we got a ductus venosus. Basically, the umbilical vein carries oxygenated blood from the placenta to the infant through here. Blood bypasses the liver through the ductus venosus, and when the umbilical cord is clamped and cut, which should happen immediately after the baby starts breathing after being out for mom, the blood flow stops and the ductus venosus closes. I have not heard of incidents where this doesn't close, and if it doesn't, I don't know if it's necessarily a cardiac thing, so I can't really answer questions on if this has ever stayed open, and what they do or how they treat it. I'm not familiar with that. So after this little ductus venosus shrivels away, immediately after that cord is clamped, then blood starts flowing into the liver and becomes useful. Up top there, in between the atria, you've got that foramen ovale, or ovale foramen. And foramen just kind of means hole. If you've studied your bones in A&P, you know there's a lot of foramen in the body. So basically the systemic blood comes into the right atrium, just as it does in a regular heart, but this is our fetal heart. and oxygenated blood flows from the right to the left atria through the foramen ovale, because we don't go to the lungs, remember? So blood bypasses the lungs. They're not functional at this point because we're just cletus the fetus. We're still inside mom. We're not breathing air. And then blood flows from left atria to the left ventricle through that mitral valve, and then out the aorta through the aortic valve. And then the foramen ovale closes after birth with the change in pressures in the cardiac chamber. So the baby starts breathing, and we start shifting blood into the lungs, and that foramen ovale should close. If it stays open, then there's ways that we can close it, but it usually closes. We'll get to that in a little bit. And then finally, that ductus arteriosus, if you can see the aorta up there and then the pulmonary arteries, there's like that little tiny pink connector that shouldn't be there. That is a ductus arteriosus, and that's a fistula between the aortic and pulmonary arteries, which allows for the mixing of blood. Blood flowing through the pulmonary artery may enter the aorta through that PDA, patent ductus arteriosus, we'll call it a PDA, and it should close immediately after birth. Sometimes it can take a couple days, but within the first few breaths it should close and then kind of turn into a little chewy ligament or shrivel up and die altogether. Just a little cartoon to show you about auscultating or listening to heart sounds. Up top you've got aortic and pulmonic, and then down towards the middle left is the tricuspid, and then in the left corner below the nipple line should be your mitral. So if you notice this kind of picture of the heart, you can see that if you were to look at the sternum more clearly, if we didn't see the heart, that you would see that on that right side of the person, and we're talking the person's right side, not my or your right side as we're looking at that, that's 1/3 of the heart, and then over there on the left side of the person is 2/3 of the heart. So this is one of the things that whenever you're looking at a chest x-ray, you should see. You should see this kind of angled shape of the heart. 1/3 should be on the right side and 2/3 should be on the left side if we're looking at that sternum. So the heart is also angled a little bit differently to where the right side is more on the front and the left side is kind of a little bit posterior, and that's why these vessels are the way they are. That's why, you know, we're not seeing the right side of the heart has the, you know, pulmonary artery section, and then why isn't the left side having the aorta? It's because the heart is also angled a little bit. So when we talk about right and left side of the heart, keep in mind that the heart is kind of twisted a little bit posterior. So let's continue on talking about the x-ray and other cardiac diagnostic tests. So some of the things that we can see from the x-ray, like I was telling you, from that 1/3, 2/3, we can see if it's enlarged, perhaps they have a cardiomyopathy. We can see some pulmonary vascular markings, or we can see the lungs. Do they have congestive heart failure? We can see from the shape or the way that it lays in the chest cavity whether they have a truncus or a tetralogy of Fallot, things that we'll talk about in a little bit. So just some interesting things that we can get from that, although more in-depth tests are needed for actual diagnostics. The x-ray doesn't really need a whole lot of nursing consideration. You just got to keep the kid still for a couple seconds while they snap a picture. Parents often ask about the amount of radiation that the child is receiving, but if the child is, I think, over 3 months or something like that, an x-ray is equivalent to a couple hours in front of the television, which I'm pretty sure this day and age children have more than that every single day. So if they're that concerned about radiation, you can give them that little education topic and ask them to put down the iPad or the television. The echo or echocardiography, whatever you want to call it, is a way that we can actually have live action pictures, live action motion. We can see how the valves are working. We can do this externally with a little bit of gel and a kind of a Doppler through the chest, which is important. You got to keep that kid still and not really crying, because that can definitely obviously stress out the heart. Or we can, with a sedated child, usually we do this in the postoperative and preoperative. We'll do this before and after surgery to see how well a heart surgery went. We'll use a transesophageal echo, or a TEE, which is kind of this tiny little box on the end of this long, long wire, and we kind of slide that down the esophagus until it's close to where the heart is, and we can get a really nice view of the heart there. No really considerations, although you know you have to have a sedated child for a TEE because no child's going to let you jam a box down their throat. And you need to have a still child for the Doppler for the echo. So sometimes for younger kids, as babies, you can often like milk feed them. We'll put them in a milk coma, so give them a big bottle of formula or whatever, and they'll go right to sleep, and that usually works. We usually don't have to do too much sedation for these things. The next is the electrocardiogram, or ECG. This can also be called an EKG. They're the same thing, except for EKG stands for electrocardiogram with a K, which is the German version of it. So ECG and EKG are the same. Holter monitor for kids that maybe have passed out. And fainting, by the way, is not a benign thing. If your child is fainting, this is something that needs to be seen. So a Holter monitor, they can wear that for 24 hours. Sometimes they can wear them for 30 days. And basically this just monitors the heart and sends a signal and report to your doctor if something is happening. Some of them actually have buttons where the kids can push a button whenever they're feeling whatever they're complaining about, flutters or palpitations or dizziness. And then a stress EKG or stress ECG is basically where we hook you up to a 12 lead and put you on a treadmill, and every 3 minutes the treadmill gets faster and with a bigger incline. So it is exactly what it sounds like. It is a stressful situation, and they examine how the heart responds to that rhythmically. And then we can also do a stress echo as well. So after you've done that stress test of the EKG running on the treadmill, we can lay you down real quick and do an echo and see how the valves are working. Is there any regurg? Are those valves loose? Are they not sealing up after they pump the blood? And then finally, we have the most invasive, which is a cardiac catheterization, or a cardiac cath, or a cath. We traditionally go in femoral arteries and veins with this, but we can go through the neck, or in adults you can go through the wrist. But traditionally with children we go through the femoral artery or vein, depending on what we're doing. This can be diagnostic, just to check pressures of the heart or to basically see what's going on in there, or it can be interventional. Are we trying to close up a hole? Well, we can do that through a cath. We can have this long guide wire with like this wonderful device that expands whenever it gets to the hole of the heart and seals it right up. It's pretty amazing what we can do in the cath lab these days. But some considerations after that is that the kid has to return and recover to one of the units and has to lay flat from like 4 to 6 hours, depending if they went through an artery or a vein, which for some kids is really challenging, but we try not to irritate that vessel. We want it to clot up and seal quite nicely. They can have a hematoma in the area afterwards, a little bit of bleeding. We have to be really gentle with that. We'll do a lot of discharge teachings with cardiac caths, and I will tell you more about those in the next slide. All right, so more about the cardiac cath, which you probably know about from adults. However, most adult cardiac caths are like angioplasties, where they go and drill out all that plaque and cholesterol and nastiness. A lot of pediatric cardiac caths can be diagnostic, where we measure pressures from valves and oxygen levels and things like that. So pre-procedure, of course, the kid is going to have to be NPO. We'll usually show them around the area. We'll allow them to bring a lovey or whatever their favorite blankie or stuffed animal is from home. Parents can be there while we give them the initial sedation, which is typically oral Versed. It makes parents quite uncomfortable when we give them Versed, or midazolam is the technical name of that, because the kids get drunk. It's quite funny, but it makes parents uncomfortable. So we take away their little drunk kid, and then we actually do the invasive lines and the actual anesthesia to put them to sleep. for the cath lab. So make sure you're educating the family, showing them around. And, you know, from your growth and development class, know the age of your child. Does the child need any explanation, or do they want to touch some of the items that can be used? Like, what do you need to do to get them ready for that? So you basically give do baseline vital signs and labs. You want to make sure that they don't have like bleeding disorders, so they would have had a PTINR or some coags. You want to do an H&H just so you know they've got enough oxygen carrying hemoglobin in their body. So we'll do the cardiac cath, and then afterwards we'll monitor for that hematoma, which is the bruising around the site, hemorrhage, and a thrombus. So we're going to check pedal pulses if we went into the femoral artery and vein. Definitely checking pedal pulses every 15 minutes, then to every 30 minutes, every hour. These kids, like I said, have to lay lie flat for 4 to 6 hours, sometimes longer if they re-bleed. So if they've got the cath early in the morning, they usually can go home at night, but sometimes if they got the cath in the afternoon, we'll just keep them overnight just in case. They'll usually have some nausea and vomiting because that's basically the effects of anesthesia. Anesthesia doesn't just put a kid asleep, it puts your whole GI system asleep. So when the kid wakes up, it doesn't necessarily mean their stomachs and intestines are woken up and that they're ready to eat. So they always want to eat. We'll start with clears. They always vomit it up, and then it's very upsetting to everybody. So make sure you're educating family on that as well. Obtaining frequent vital signs because we want to make sure that they're not bleeding out on the inside. Please know your signs and symptoms of hemorrhage like tachycardia and falling blood pressure, loss of pulses, things like that, and pallor, which are some late signs. But know that kids are not like adults. Kids can compensate like nobody's business, and then they hit a wall, and then you're in trouble. So, but the most important thing for caths to know for like NCLEX is making sure they lie flat for so many hours, monitor that site, monitor the pedal pulses, because typically we go into femoral sites. And then discharge teaching, you know, we just usually put a Band-Aid over it. They come back with a pressure dressing. If you haven't seen that, it's like a wad of gauze and some pressure stretchy tape, just because you always want to hold pressure on that. We'll take that off at the end of their flat time, send them home with some betadine and a Band-Aid and everything, and discharge teaching. Now, if you've already listened to Ms. Davis's lecture, then you should be really, really hip to EKGs and 12 leads and rhythms, so I shouldn't have to go over it. This is just a little cartoon showing you what's happening at each of these moments, from the P wave to the QRS to the T. So just be familiar with it. It's not too much to do with pediatrics. It's pretty rare that we have rhythm disturbances standing by themselves. Most of our issues are congenital heart defects, and then after we repair them, we create rhythm issues. So we have a lot of rhythm issues in the cardiac ICU. There are some things called channelopathies, which are these inherited genetic kind of long QT syndrome or dysrhythmias that we see in children. And it's quite interesting because people don't know about it, but you know, one day your kid will faint playing a sport or something like that. We bring them in and we realize that they have a very, very long interval from their QT, or their PR interval is incredibly long, and it's an inherited disorder, and we test everybody in the family and you find out all the siblings have it and this and that. It can typically be managed with insertion of a pacemaker and defibrillator, which I know is a scary thing, but also an interesting thing because then you have like a little lifesaver in your body at all times. So if you're interested, look up channelopathies and long QT. So you should be familiar with congestive heart failure from your adult lecture. There's only one real major difference. In adults, you're traditionally going to have a left-sided congestive heart failure or a right-sided CHF, but in children, you typically have a biventricular failure, and that's just because the heart tries to compensate for the other, and then it just gets worn out, and we have that biventricular failure. So anybody with coronary artery disease, a history of an MI, hypertension, diabetes, pericarditis, any pulmonary conditions, anything like that, is at risk for congestive heart failure. So in kids, typically we have congenital heart defects or acquired heart defects like cardiomyopathy, and these are the things that put them in risk for congestive heart failure. The heart just is basically unable to pump what the body needs, and that's pretty much the definition. So what's happening during CHF? Well, the left ventricle is unable to pump the demands of the body, so it's unable to empty out all of its blood, which gives us an increased left ventricular preload. Now, preload means the amount that's in the heart before we've done the squeeze. Afterload, if you're not familiar, means the amount of pressure we're pumping against. So basically, what the body's resistance is to us pumping out. So whenever we talk in the future, or you may talk about this in med-surg with preload reducers and afterload reduction, that's what that means. A preload reduction means I want less volume going into the heart, and afterload reduction means I want the heart to have to pump against less pressure. So let's dilate those vessels or something like that. Let's do something to where the heart does not have as much resistance or afterload. That's what those two terms mean. But anyway, back on track. So the weak left ventricle is unable to pump all of its blood out, which means that we have an increase in left ventricular preload. So then I have a decreased amount of cardiac output. You should know cardiac output is stroke volume times your heart rate. And then left atrium has difficulty emptying because of the increased preload on the left side. So if the left side isn't emptying, then the right side isn't able to, do its job. Because of that, the left atrium now overfills. Then the pulmonary veins are unable to return all the blood from the pulmonary arteries. This is why it comes in handy knowing that whole blood circulation thing. So because the pulmonary veins are unable to return the blood from the pulmonary arteries, a buildup of blood in the pulmonary arteries happens. That causes pulmonary congestion and increased pressures within the vessels. And then we're now forcing fluid into the alveoli, into those very tiny sacs where in respiratory we talked about that's where oxygenation should happen. And the patient feels like they're drowning and they have wet lungs. So now we have fluid going everywhere. And we have pulmonary symptoms. We have decreased saturations because we're not sitting there and exchanging our gases in those alveoli or those capillaries down there. We have, we can auscultate lung sounds, whether it's atelectasis or wet lungs or diminished lung sounds. We have high pressures and congestion of the pulmonary symptoms, so we can't empty our right ventricle. The right atrium can't empty, and the venous system is unable to return the blood. So now we have generalized edema and swelling, especially dependent edema in our kids that are in the bed. And then because of that, then we have what we call third spacing, which is the edema, and we're just puffy, so we have both symptoms, and that's how biventricular heart failure happens in our kids. Learn the blood flow of the heart. So what do we do now? We have both sides are failing in the heart, so how do we fix this? What do we do? The body attempts to compensate for the low cardiac output, and it can actually make the problem worse. So like I said, afterload equals the resistance of the ventricles that they need to overcome to eject the blood. So that's the resistance that the body is giving it to empty those ventricles. So what is happening? What's some compensatory mechanisms? How is the body trying to fix its own problem? One is related to the Frank-Starling law, which if you guys don't know this, just turn off this PowerPoint and walk away. The Frank-Starling law is basically like the rubber band thing. The more you stretch that rubber band, theoretically, the harder it's going to snap back at you. So we think the more we fill the heart, the harder it's going to snap back at us. However, this is to a point, because if we continue to stretch that rubber band or continue to overstretch the muscles in the heart, then they're actually going to get overextended and not have as good of a snapback. So please familiarize yourself with the Frank-Starling law. It's the first compensatory mechanism. So decreased cardiac output stimulates the aortic baroreceptors, which stimulate the release of norepi or norepinephrine to increase heart rate and contractility, which leads to vasoconstriction of the arteries to increase the left ventricular afterload, which makes the already weak left ventricle work harder to pump. So if you're following me, I just said that the decreased cardiac output, so the heart is not emptying all the way, the left heart, It stimulates baroreceptors in the aorta, and which makes the aorta think that we somehow don't have enough fluid. If we're not having enough fluid, that's what the aorta is thinking. So it releases norepi, which norepi stimulates the contractility or the constriction of the vessels. Well, I just told you the afterload is that pressure that the heart is trying to pump against. So now we've constricted vessels. Well, that's really going to increase the afterload, which we didn't want in the first place. The heart is kind of messing us up right now because we're now vasoconstricting. And so this is making actually the left ventricle work a lot harder than it should because it's trying to pump against now those vasoconstricted or vessels that are vasoconstricted. So now the body realizes that it doesn't have as much blood flow because of the vasoconstriction and our left ventricle isn't emptying. So decreased blood flow through the kidneys, when we get to renal, oh my gosh, it's probably one of the most complicated topics, but I do love renal, and hopefully you've already listened to renal with Miss Davis. But decreased blood flow through the kidneys stimulates another trigger, and that's the renin-angiotensin system. So whenever you're not pumping enough blood to those kidneys, and those kidneys need to have constant blood pressure, then they think that, oh my gosh, we don't have enough fluid, we don't have enough blood, we don't have enough volume in our body. So now we're going to stimulate the renin-angiotensin system, which is going to produce angiotensin 2, which is also a vasoconstrictor. So that's also now increasing our afterload. So decreased blood flow through the kidneys stimulates the release of aldosterone as well, which causes the reabsorption of sodium and water because our kidneys aren't getting enough blood flow, so they think that we're low on volume. So now they're going to release aldosterone, saying stop peeing and just reabsorb water and sodium. And remember, where water goes, sodium flows. No, wait, where sodium goes, water flows. Yeah, that makes more sense. Do that one. Anyway, so the kidneys have now released the aldosterone as well that's causing the reabsorption of sodium and water, which increases the cardiac output, but except for we're not increasing cardiac output because our left ventricle is getting completely stressed. So basically, it's just kind of this vicious cycle. I hope you followed that. Replay this. I'm not going to let it go that easy. I just want to clarify. Left ventricular heart failure. The heart is not emptying enough, so all the fluid is not getting delivered, or all the blood is not getting delivered to the aorta. The aortic baroreceptors think it's because we're hypovolemic or we don't have enough volume. So they release the norepi. The norepi constricts our vessels, which makes it harder for the left ventricle to pump out against because now we have this resistance. Also because of the vasoconstriction from the norepi, the renal system or the kidneys are not getting the blood that they want, so they think we're also hypovolemic. So they do two things. They stimulate the renin-angiotensin system, which produces angiotensin 2, which is also a vasoconstrictor, and then they also produce aldosterone or stimulate the release of aldosterone. They don't produce it, they stimulate the release, which causes the reabsorption of water and sodium, which means that we're not going to pee. So now we're going to hold on to our water and our volume, which is actually going to increase the preload in the left ventricle because now we actually do have volume. We weren't lacking volume to begin with. We've got it. We're just not able to pump it out because the heart is in failure. So all this stuff is backing up into our body in the form of edema or third spacing. It's backing up into our lungs in the form of pulmonary congestion. So just to clarify, that is the vicious cycle. Hopefully you got it now. Keep listening. So now that we know about left-sided heart failure, which backed up and led to the right-sided heart failure, which ultimately in our kids leads to biventricular heart failure, let's talk more about what it looks like and how we'll treat it. So the first sign is going to be tachycardia or an increased heart rate, just because the body is going to be trying to compensate for not emptying the heart and not delivering the amount of blood. It thinks that maybe if it pumps faster, it will deliver the appropriate amount of blood since the heart isn't emptying. We're going to have increased respirations because in the alveolar and the base of the lungs, we're not getting appropriate oxygenation because we're full of fluid. So we're going to breathe faster to try to compensate for gas exchange. Retarded growth. These kids are working so hard to breathe, and their heart is working so hard to pump out enough blood that they're going to not grow consistently with the growth chart as they should. So because of that, they're going to need high-calorie meals and make those small kind of frequent feedings, not big meals, which can be exhausting to a kid. Obviously, you're going to have fatigue and then upper respiratory infections because of all that fluid that is being backed up into the lungs. You'll also be able to give them DIG or digoxin, ACE inhibitors. ACE stands for angiotensin converting enzyme inhibitor. So we learned on the last slide that part of heart failure is the kidneys stimulating the release of angiotensin and aldosterone. So now we're going to give ACE inhibitors to try to get some of that fluid off, some diuretics to try to give that fluid off, which of course means you're going to want to monitor your electrolytes because depending on what diuretic you give, it could be potassium sparing or potassium wasting. And then find out what the underlying cause is and treat that. Okay, so digitalis, digoxin. This is something that you really need to do your very best to educate family on. I can't tell you how many times I see kids coming back with dig toxicity. It's probably the #1 cardiac overdose drug. Parents or caregivers drop them off at babysitters or grandma and grandpa's, and they overdose them because dig is in micrograms, and 1 mil is 50 micrograms. Well, these kids are getting 25 mics or 12 mics, 12 and a half mics, things like that. So they're getting a fraction a milliliter. And what happens is that grandma and grandpa or the babysitter doesn't understand that, and they're drawing up the 12 and a half milliliters or the 25 mils or something like that instead of the fraction of the mil. They're drawing it up for the micrograms, and our kids are overdosing, which is unfortunate. So you should never, ever, ever be giving a child more than 1 mil, one tiny mil of dig. So they should just have a special tiny 1 mil syringe. If you're drawing up more than 1 mil, you need to triple check it, check with another nurse because it's usually not right. So send them home with 1 mil syringes. If you miss the dose, don't redose it. Don't try to catch up on missed doses. If they vomit, it got absorbed in their mouth, do not redose it. Hold it if your heart rate is less than 100 in an infant, less than 70 in a child, and 60 in a teen. This is important to know. This is usually tested. And always check your apical pulse before administering. And then look for dig toxicity, which in adults it's like the halo and all that thing, but you can't really ask the kids if they're seeing halos. So basically, if they're toxic, it's going to be vomiting and bradycardia, and those are the things that you're going to see in the children. You should already be familiar with ACE inhibitors from the adult lecture. ACE, angiotensin converting enzyme inhibitor, so it inhibits or stops angiotensin from converting over. So basically, like we talked about so eloquently, might I add, in the congestive heart failure slide, was that the kidneys are perceiving that lack of blood flow because the heart isn't emptying. They're perceiving that is that we're hypovolemic, so they release the angiotensin, the aldosterone, that whole renin-angiotensin system that is really, really detailed but super interesting. You should listen to the renal lecture if you're not familiar with it. So basically, ACE inhibitors, we give them to patients. They block the formation of the renin in the kidney, which the renin causes vasoconstriction. So if we're blocking that, then basically we're allowing those vessels to vasodilate. Vasodilating is allowing the left ventricle to empty maybe a little bit more, because vasodilation means a decrease in afterload. We're decreasing that pressure, that force that the left ventricle has to pump against. So the blocking of the renin, the ACE inhibitor, allows for vasodilation, which hopefully decreases in afterload, which hopefully helps that left ventricle empty a little bit more than it was. And then by also blocking the aldosterone, then we're allowing us to urinate a little bit more and void a little bit more to kind of take off of some of that extra water. All right, so down to the meat and potatoes. I did include slides for the most common defects, but I'm not going to say much about those because essentially all you really need to know about congenital is the varying types, which are the acyanotic and the cyanotic, and then the types of those, the obstructive, and so on. So we'll talk about those. And then they'll also want you to know acquired disorders. So these are things that you're born with a normal heart and then you've acquired them. So the hypertension, the hyperlipidemia, rheumatic heart disease, Kawasaki's, things like that. So I will try to keep it simple. Wish me luck. So first we're going to talk about congenital heart defects, and these are defects that children are born with. They're developed in utero. The heart structure is one of the early structures to form. It starts out as a tube, and then the valves and chambers develop through something called an endocardial cushion. It's really interesting how it goes from a single hollow tube into this amazing organ that it is. So if you have time, take a look at it. I'm sure there's something on YouTube. But it's important to know that the two major congenital heart defects are acyanotic and cyanotic. Acyanotic, sometimes colloquially called pink, and cyanotic, sometimes called blue. I'll do a brief overview, but it's just important for you to know which one is which. And I'm telling you, if you memorize the flow of the blood through the heart and the vessels, then you'll be able to guess which one is which, because you'll be able to guess by the name. An ASD, an atrial septal defect, you'll be able to guess where the blood is going and whether or not they're going to be pink or blue. I promise. So the pink ones are going to be two different kinds. An increased pulmonary blood flow. So if we're getting blood to the pulmonary system, we're definitely not going to be a blue baby. And then obstructive ones. So we'll talk about those. And then cyanotic, where the blue babies are ones that obviously don't have enough pulmonary blood flow, or they have a mixing of blood flow. And I promise I will be brief, because really all you need to know is which one is which and how to tell the difference and if they're blue or pink. So please memorize the blood flow system. So first we'll talk about the acyanotic congenital heart defects. That's going to be your patent ductus arteriosus, the PDA, the atrial septic defect, the ASD, and the VSD, which is the ventricular septal defect. These are heart conditions that don't cause any deoxygenation or low oxygen levels, so these kids' stats will be fine. And their skin and mucous membrane is going to be pink typically, because we're not going to be acyanotic. So these are sometimes called pink defects. These kids are going to show pretty typical signs of all congenital heart defects, and that's going to be the fatigue, heart murmur, congestive heart failure. They're going to probably be poor feeders just because of, the congenital heart issues and the tachycardia, tachypnea. And because of that, they're also going to have a slower growth. They're going to be smaller than a lot of other traditional babies because of their heart rate and their respiratory rate. Just kind of slows them down, and it burns a lot more calories to be them than a child without a defect. So PDA is very rarely tested on. I'm not really going to say much about it. Basically, remember that PDA was that opening from the pulmonary arteries to the aorta whenever they're in utero, still cletus the fetus, and it closes and turns into a ligament when they take a breath. Well, sometimes it stays open. And also sometimes we want it to stay open, and we'll talk about that when we get to the cyanotic defects. Sometimes we'll want that safety valve so blood can mix. But normally it closes. If it doesn't close, then we'll give them something like indocin or indomethacin or ibuprofen, and it actually closes it. And if it doesn't, then we can do a simple cath lab procedure and do a PDA ligation or coil. or sometimes it might need to be a thoracotomy, but pretty much nothing needs to know except for if it stays open, then blood that's going out the aorta is going to also take that little tunnel, that path of least resistance, that PDA, and it's going to go into the pulmonary arteries, which go to the lungs, and then the lungs are going to get overloaded. All you need to know. That and how to close it: indomethacin, ibuprofen, or PDA ligation. So let's talk ASD, which is an increased pulmonary flow, acyanotic pink defect. Remember we were talking about the foramen ovale. This is very similar, except for this shouldn't exist since we're post-mom, we're already been born, we breathed our air, so we should not have an ASD. Remember, the left side of the heart is stronger than the right, so if we have a hole up there in between the left and right atria, the left side is going to send blood over to the right side because it's stronger, and the right side delivers blood to the pulmonary system, so now we're going to have pulmonary overcirculation. So if I mean, this is insensitive, but if I had to have a heart defect, I would definitely want my child to have an ASD. It's the most common, but it's the easiest to deal with, easiest to fix, and has the best prognosis. If they have an ASD less than 3 millimeters, usually we let it go and it closes by the time they're a toddler or 2 years of age. If it's 3 to 8 millimeters, I think about 80% or 75% of them close on their own. If it's bigger than that or it doesn't close, then we'll take them to the cath lab. And if it's small enough, we can put in an amplatz or a device that kind of occludes it. If it's too big, then we'll take them into the OR and we'll put a patch on it. And that's pretty much all you really need to know, is that it's the risk of pulmonary overcirculation. There's a hole in the heart, we can fix it, and then you should know the signs and symptoms of the heart failure. And yeah, no, that's all. Signs and symptoms of congestive heart failure. VSD, very similar to the ASD, except for now we're down in the ventricles, and still the left side of the heart is pushing it over into the right side. Now, because the left ventricle has more blood than up in the atrium, we're pushing more blood over to the right side. So now our pulmonary system is getting even more blood delivered to it. And also the left ventricle, since it's sending so much over to the right ventricle, it has to compensate with a squeeze extra hard and extra fast to deliver out of the aorta to make sure our body gets all the blood that it wants. So sometimes we can be at risk for left ventricular hypertrophy or just overgrowth or too big of muscle on that left ventricle. So that is something to be concerned about. Typically we take these kids to surgery and we either patch the VSD if it's small enough, or if it's too big, we'll do like a PA band, a pulmonary artery band, which means that we kind of squeeze that pulmonary artery a little bit so it won't accept all that blood flow that the right ventricle is sending it, because the left ventricle is dumping all its blood over there. So sometimes we can do that as well, but typically we're able to just do a VSD patch. Now the VSD it's kind of rare that it happens alone, but then again, a lot of these defects are rare that they happen alone. They usually happen with other things. So a VSD you might see with other congenital defects. And again, with every single one of these defects, the same teaching that we talked about for the cath lab. Make sure that you're talking to these families about outcomes, expectations, you're orienting them to the OR, to the room, to the daily plan. Make sure that we're, monitoring calories, we're monitoring I's and O's and daily weights and all that, because we're in congestive heart failure. Make sure we're doing med teaching. All that stuff that you would do with adults, do it twice as awesome with parents and children. I just included this slide just because I have to include all my cardiac stuff, but you'll probably not be tested on it. An AV canal is still acyanotic. It is still increased pulmonary flow. It's a AV canal, atrioventricular canal. So basically we have a hole that encompasses the atrium and the ventricle, just kind of one large hole in the middle of the heart there, so that's kind of an issue. Still left to right shunting, so still increased pulmonary flow, still going to have the signs and symptoms of congestive heart failure and the wet lungs and the poor feeding and the poor growth. We do want these kids to grow a little bit before we take them into the OR because this is a bigger surgery, so we try to let them grow to be 3 or 6 months. This could require NG or G-tube feedings, gavage feedings, because it is a lot of work for these children to have to eat from a bottle or a breast, to have to like suck and swallow and breathe and do all that. That's very, very challenging for a baby, especially one that already has tachypnea and tachycardia from the congestive heart failure, from the heart defect. So we'll wait until they grow and fatten up a little bit. This is one that's actually commonly associated with trisomy 21 or the Downs children population. So when I see an AV canal is on our surgical roster, I get excited because I love Downs kids. They're the best. Okay, again, I doubt you'll be tested on this, but I would be doing you a disservice if I didn't include it. So pulmonary stenosis is still acyanotic, it's still a pink defect, but rather than it being a defect of increased pulmonary flow or too much pulmonary circulation, this one is actually obstructive. So basically, it's just like it sounds. The pulmonary valve or the pulmonic valve, the one that goes to the pulmonary artery, is stenotic or malformed or small or cramped or something like it that is preventing it from accepting the blood. So it's preventing a proper amount of blood from going to the pulmonary arteries, which then go to the lungs to get oxygenated. So that's pretty much it. Basically, we'll take them to the cath lab and we'll do a balloon dilation of that valve, and if it doesn't work, then at an older age we will take them and replace that valve, which typically is called a valvotomy, and usually it's a melody valve that we'll put into that pulmonary valve place, which can also be done in the cath lab, which is amazing, really. I mean, how cool is that? That can be a cath lab procedure for that valve. Anyhow, so basic signs and symptoms, sometimes they can be asymptomatic. They can have an enlarged heart because that right ventricle is working so hard to try to squeeze blood through that pulmonary valve that is too small or not working right, because it wants to deliver blood into the pulmonary artery, but it's just not working. So you can have that right ventricular hypertrophy, which you can sometimes see on x-ray. Oh, and if you're wondering why we just don't go and replace the valve to begin with, it's because we want to make sure that the kid is big enough to where you won't have to keep replacing the valve, because these valves, they don't grow with the child. So we wouldn't want to go and put in a valve in a child and then have to keep replacing it, with growth spurts. I mean, any of you with children know that kids grow super fast. They grow out of their clothes and their shoes. We can't have them growing out of their valves. So we'll balloon them until they get into like adolescence, until we think we're done with their growth spurts. Aortic stenosis, just like it sounds, and if you know the flow of the blood through the heart, then you know what this problem is. So aortic stenosis is another obstructive or pink acyanotic defect. So the aortic valve, which is connected from the left ventricle into the aorta, is malformed or fused or narrowed, or something is wrong with it that is not allowing blood to flow past it freely from the left ventricle into the aorta. And well, the body needs the blood to be delivered through the aorta, so this can have problems because of that. So also the left ventricle, if it's not able to empty completely through that aortic valve, through the aorta, then we can have low cardiac output. The left ventricle can get hypertrophied or too big and stretched out because it's trying to work so hard against that valve, and then obviously we have blood backflowing through into the left atrium, and then so on and so forth. And since you've memorized the flow of the blood, you know what that means. So typically it's asymptomatic, except for the traditional poor feedings, poor growth. Because it's an issue with the aorta, we can have hypotension. We're definitely going to have the tachycardia. And again, because the hypotension and the aortic involvement will have weaker pulses, especially in the lower feet. Sometimes these kids are smaller in the legs than you would expect them to be. That also goes with a coarctation of the aorta, or the coarc, which is where the aortic valve is okay, but the aorta itself is pinched off somewhere. And it's quite interesting. These kids come in and they've just got little baby bird legs compared to the rest of their body because there wasn't proper delivery or flow of blood. So same goes with this aortic stenosis. We're going to dilate them in the cath lab with the balloon dilation until they're big enough to get an aortic valve. And here we are with the coarc, or the coarctation of the aorta. It is still acyanotic, it is still obstructive, it is somewhere a narrowing of the aorta. Sometimes this has to do around, it's involved in the site of where the PDA was, the patent ductus arteriosus. Remember how that PDA goes from the aorta to the pulmonary arteries, and then after we start breathing as babies, it closes up and turns into like a little ligament. Sometimes that ligament can get a little tight and a little attached and can cause a coarctation, or sometimes this coarc can just develop naturally in utero when the cletus, the fetus, is trying to develop. So anyway, what we're going to see in a coarctation is because the heart is working so hard to pump against this coarc that we're going to have blood pressures in our upper extremities that are going to be 20 or higher than our lower extremities. So this is really interesting. You take a 4-point blood pressure to both upper arms and both lower legs on these kids, and you're going to see that the upper is 20 points or more higher than the lower. Sometimes we're trying to recommend that before babies are discharged from the nursery, they get 2 things. 1, a pulse oximeter reading, and 2, a 4-point blood pressure, because that can sometimes be helpful in diagnosing undiagnosed cardiac defects. So there's, if any of you work in a peds hospital or know anybody who does, that's kind of a thing that we're trying to push for. There's actually legislation going around state to state right now that's pushing to require pulse oximetry, at least 1 or 2 checks before babies are discharged from the nursery. And it is actually starting here in Minnesota, the woman who is doing it. It's quite interesting. Her child was a patient in St. Louis at Cardinal Glennon, and he passed away. So this is her thing now, is she's pushing for pulse oximetry monitoring. So it's quite interesting. So same thing with the coarc as with the pulmonary and aortic stenosis. We're going to balloon them through the cath lab, and then whenever they get old enough and big enough, we're going to go in surgically and we're going to create a graft. We're basically going to slice that aorta lengthwise and we're going to slap a patch on it. And again, left ventricular hypertrophy, because the left ventricle works so hard against that pinched aorta. Baby bird legs on these little kids. Sometimes kids can become, active in sports and become school age and not even know that they have a coarc, and then one day they'll be running around playing sports and then they'll pass out because their body is pumping blood so hard and it's only getting to their upper extremities rather than their lower. So anyway, I think that kind of sums it up. Trying to keep it brief. I'm struggling though. Okay, we made it to cyanotic heart defects, blue defects. These are going to be 2 different kinds. They're going to be mixed or decreased pulmonary blood flow. So we just got done talking about increased pulmonary blood flow or obstructive. Now we're going to talk about decreased pulmonary blood flow and mixed. So cyanotic heart defects, basically they cause the blood to contain less oxygen than required, so that's why they're cyanotic or blue. Decreased pulmonary flow ones are going to have obstruction of pulmonary blood flow and an anatomical defect like an ASD, a VSD, or blood is going to have issues exiting the right side of the heart through the pulmonary artery, so the pressures on the right side will increase. Basically, that'll cause the pressures for the left side to increase, which is how we get that biventricular heart failure. And our blood does not get oxygenated. So basically, these kids are going to be blue, hypoxic, and cyanotic. The mixed ones it just depends on how the blood mixes. Postnatal survival depends on where it mixes and how, and then where the blood from the pulmonary and systemic circulations kind of meet with one another. These are the ones that we're definitely going to involve that PDA, or that patent ductus arteriosus. We're going to want to keep that open for a lot of these kids. So they're going to have some desaturations, maybe not always a chronic cyanosis, but they can have like spells where they'll desat into the 30s, 40s, and 50s. Which I know you're having a heart attack, but I only bat an eye whenever they get into the 40s, and we'll talk about that later. But another issue with mixed blood flow is that they have decreased cardiac output, pulmonary congestion, and things like that. So let's get on that. So first we'll talk about a decreased pulmonary flow cyanotic or blue defect called a TET, or a tetralogy of Fallot. Tetralogy means four, and Fallot is the humble doctor who discovered it and named it after himself. So there's four defects as why it's called tetralogy, and that is going to be pulmonary stenosis, which can be called right ventricular outflow tract obstruction. I know that sounds like a lot, but think about it. Right ventricle, outflow tract. Where does the right ventricle outflow or push out? And it pushes out in the pulmonary valve into the pulmonary artery. So if it's a right ventricular outflow tract obstruction, obviously there's going to be some issue around that pulmonary valve area. So pulmonary stenosis, or RVOTO, right ventricular hypertrophy. That's obvious, right, everybody? Because if the right ventricle has a hard time pumping its blood out through that pulmonary area, then of course it's going to get all big and strong and stretched out because it's trying to pump so hard. We're going to have a VSD. Now, if we have a big fat right ventricle and nowhere for it to pump out because that pulmonary valve is all jacked up, then we have this VSD. We're going to have a right to left shunt now, aren't we? And then we have an overriding aorta. So because we have that VSD, the aorta, which normally, remember, sits over there in that left ventricle side, is now going to hang out over both sides. So it's going to get blood from that right side and from the left side. And that's why we're cyanotic. So we have a right to left shunt. The pulmonary stenosis limits the blood from the lungs. And then with that VSD and the overriding aorta, all that unoxygenated blood from that right side is allowed to go straight out into the aorta, into our body. And that's why it's cyanotic. That's what makes it different from just a regular old pulmonary stenosis, is that this unoxygenated blood has a shortcut to go into our body. Okay. TET spells. These are super scary, super dangerous if you're not hip with the TET. So these kids, what happens is they can have like this kind of pulmonary circulation spasming and whole vascular spasming where their saturations go from 70s to 30s. And it's super scary. They basically turn black. And when I say they turn black, I mean, like, I'm not joking. They look like the skin of a blueberry. They turn black. And it usually happens whenever they get all worked up and mad and crying. And you're like, Shauna, how do you keep a baby from crying? It's really challenging. But anyhow, one of the things that we do to help them with a TET spell is we try to put them in a squatting position. So if they're old enough, if they're a toddler with TET, then they know, and they'll sit there and squat like they look like they're trying to poop in their diaper. Otherwise, if they're a baby, we'll push their knees up to their chest. We'll provide oxygen and any sort of like vasodilation, like morphine or something like that, to try to calm them and knock them out and see what we can do for them. And that's just to try to help redirect the blood flow and get them calm and get them oxygenating again. Obviously, because they're cyanotic, just as in adults, we're going to have clubbing of the digits or the fingers, and they're going to be very, very dusky or blue. Polycythemia, and that word means that we're going to have many, many red blood cells. And the reason is because our body is trying to get smart, and it's trying to compensate for our chronic hypoxic state. My body says, oh my gosh, we're only satting 70% all the time, every day. Let me make more red blood cells. Let me make more of these cells whose job it is to carry oxygen. Maybe that's the problem. The body doesn't recognize that the problem is that we're not able to oxygenate the blood. So we'll make more red blood cells. And you're like, oh, what's the harm in that? Well, the harm in that is the more red blood cells you make, the thicker your blood gets, and then the more your risk for things like occlusions and stroke and clots. And they're obviously going to have a murmur. I mean, look at their heart, for goodness sakes. And they're going to have poor growth, because how can you properly grow and eat and just develop whenever you have this horrible, horrible heart defect? You're cyanotic, you don't even have proper oxygenation, you're not eating obviously okay. Just a whole host of a mess. So treatment, we're going to do prostaglandins. And why are we going to do prostaglandins? Because a prostaglandin is what keeps that PDA, or that patent ductus arteriosus, open. Why do we want that open? Because we need some of that blue blood, some of that deoxygenated blood that's accidentally going out of the aorta from that VSD and overriding aorta. We want that to hop its way down into the pulmonary arteries and go to the lungs and get oxygenated. So remember, a PDA, patent ductus arteriosus, is that little tunnel from the pulmonary artery to the aorta. So, and blood is always going to take the path of least resistance. So this way we're having, yes, that blue deoxygenated icky blood going out our aorta by accident, because the aorta is hanging over that VSD, so it's on both sides. But now at least some of that deoxygenated blood is going to take that PDA path to the pulmonary arteries, which are going to go to the lungs. So at least we're going to get some partial oxygenation. So it's super important to keep that PDA open. Anyway, if you want to know about the surgeries to fix this, it's a lot of different surgeries, but one of the most popular is the BT shunt, or Blalock-Taussig shunt, and that is named after Dr. Blalock and Dr. Helen Taussig. If anybody has HBO or wants to rent it on Netflix or Hulu, if you can watch Like Something the Lord Made, it's really, really good movie about how the BT shunt was created. It's got Mos Def in it, which was, he was like this lab assistant, and it was before African Americans were allowed to be in medical school. And anyway, it was super amazing, and he contributed greatly into the development of this surgery. He was eventually given an honorary doctorate and then did go to med school. But they experimented on dogs, and it's just a really, really fascinating movie, and amazing about how this surgery was created. And I mean, I think it was maybe 60 years ago, if that. I mean, cardiology is a very, very new field. So if you have time, that's a good movie. Otherwise, moving on. All right, now a transpo, or a transposition of great vessels, sometimes called a transposition of great arteries. Your heart is delivering blood to two major arteries, and that is the pulmonary arteries and the aorta. So, the aorta comes out of the left side and the pulmonary arteries come out of the right side. Well, this is a transposition, or sometimes called a malposition, and it's just like it sounds. The aorta is on the right and the pulmonary arteries are on the left. Now, take a look at this picture and see for yourself that if this is the way it is, and we don't have any like VSD or ASD or whatever, we have two separate circles, and there is no way any of this blood is mixing. So it's very, very interesting. So obviously, again, we want a PDA open, the patent ductus arteriosus open, because we want some of this blood to start mixing. Otherwise, we have a blue circulation and a red circulation, and they never touch. It's very, very crazy. Take a look at the picture. And, since you've got your blood flow memorized now, just say it to yourself and realize that none of these bloods are ever touching. So it's quite fascinating. But anyway, this is something you can see on a diagnostic ultrasound for children. So we'll give them prostaglandins, obviously, to keep that PDA open. And what we'll do is we'll take them into the cath lab and we'll do a septostomy, which basically means that we'll jab a hole in that atria, and we will create an ASD, or we'll open up that foramen ovale, because we need as much mixing of blood as possible. Otherwise, this is not compatible with life. And then whenever they get old enough, the transposition repair, the switch as it's called, is very, very interesting. It is basically snip, snip, switch so-so. And it's quite fascinating. One of the complicating factors is the coronary artery. Sometimes, it's supposed to come off of the aorta, so they got to be very, very delicate with that to make sure that they don't damage the coronary artery. But it's one of the most interesting surgeries I've ever seen, aside from a heart transplant. Moving on. The hypoplastic left, or the single ventricle, the HLH, or hypoplastic left heart syndrome, this is, to be insensitive, I mean, this is the big killer. This has the highest mortality of any of the heart defects. It is very, very challenging, and the first surgery has to happen almost immediately, within the first few days or week or two of birth, and that's the Norwood, which has the highest mortality of all surgeries in the cardiac world. So basically, if you take a look at the picture, it's what it sounds like: hypoplastic left heart. That left ventricle just somehow wasn't formed in utero. So without that, we're unable to pump that beautiful oxygenated blood out of the aorta. A lot of times the aorta and the mitral and the aortic valves, that whole left side of the heart is just malformed. So we really have a single ventricle. We're just working on the right side of the heart. To fix this, we create shunts, and we basically make the right side of the heart the main ventricle of the heart for the body. We try to mix the blood enough so that the right side of the heart can pump out to the body, and it's whenever I first started, these kids were living into their teens, and now they're living into their 20s. However, because it's a single ventricle, we can never give them another ventricle, no matter how many shunts and things that we do. These kids end up actually having a lot of liver and biliary problems and pressure problems, GI problems, because just of the way that the heart pumps and the pressures. They are born and live cyanotically in the 60s and 70s, and after repairs, they're 70s and 80s, and then, with hopefully the Fontan or the traditionally the third surgery, that we can get them to the 80s and 90s. A lot of times you'll hear that this hypoplastic left heart has 3 surgeries, Norwood, Glenn, and Fontan. However, I don't think I've ever met anyone who's only had 3 surgeries. There's usually a lot of other issues, and you'll have to regular Fontan, fenestrative Fontan, a bidirectional Glenn, a single Glenn, a lot of other issues, cath lab visits. So it's a very, very challenging defect to have. The truncus. The truncus arteriosus. There's a truncus among us. We just had a string of like 7 of these things. So like a tree trunk, basically what happens is those 2 major arteries that are coming from the heart, the aorta and the pulmonary artery, instead of forming 2 separate origins, one originates from the right ventricle and the other originates from the left ventricle, somehow when they're forming in utero, their base is a single origin. So it's like a tree trunk that spreads out and becomes an aorta and a pulmonary artery. Obviously, this can have a lot of issues because the blood is way too mixed, so it tends to be very, very cyanotic in the child. So what we have to do is create a whole ventricular wall or a new septum, and kind of try to separate these 2 arteries and reform them. Obviously, they're going to also have malformed leaflets or valves, so sometimes they'll need valve repairs, and it gets pretty complicated. So again, we're gonna, treat them like a heart failure patient, because they're gonna have too much blood going to the pulmonary system. So diuretics, digoxin for the contractility. The goal is to eventually separate those 2 vessels and create new valves. All right, we're done talking about congenital heart defects, and I tried to be as brief as possible. If you want more information, just pass it on and I'll try to answer your questions. Otherwise, you're typically not tested on specific defects, just really what they're about, like the flow, of the heart and cyanotic versus acyanotic, and then just cares of congestive heart defects, congestive heart failure, and how to care for the perioperative child, which is a lot of growth and development stuff, not really specific to the congenital heart defects. So now we're going to talk about acquired, which are bacterial endocarditis, rheumatic fever, Kawasaki's, and hyperlipidemia, hypertension, and things like that. And we're almost done. So first up is bacterial endocarditis, which is basically endocarditis inside the heart, and itis meaning inflammation or infection. So it's an infection of the valves and lining of the heart. And you might hear about this with older adults that have had any heart surgery. They tell them to take antibiotics before they go to the dentist, prophylactic antibiotics. We're actually stepping away from that practice, but we still talk about it a lot. So I don't know if the evidence-based information has been disseminated, but anyhow, so bacterial endocarditis, what happens is a natural bacteria, strep or something, works its way into our blood. Most commonly, it's through dental surgery or dental work. Our teeth and our mouth are a dirty place, and we bleed a lot when we brush our teeth or get dental procedures done. So the bacteria finds its way into our blood system and works its way, obviously, into the heart. Where it kind of settles onto a valve and then builds an infection, and then you get this kind of vegetative growth on a valve, which makes the valve not work properly. Well, if the valve isn't able to open or close all the way and work properly, then we're going to have some signs and symptoms, whether it's like fatigue or dyspnea or, palpitations or something like that. When we do an echo, we'll be able to see this vegetation kind of flopping around on that valve. It's really, really interesting. So other places that you can get this aside from dental work is the urinary tract system. So you let a UTI go untreated and it goes up and becomes pyelonephritis, and then it gets into your blood system, and next thing you know, you got bacterial endocarditis, and then heart surgery is a common way of it getting in. So basically x-ray and echo are the easiest ways to see it, and high-dose antibiotics are the easiest way to treat it. And then prophylactic antibiotics before dental surgery if you have been an invasive cardiac patient. So if you've had a heart attack and they never went in and did anything, you're not necessarily going to need prophylactic antibiotics. But if you've had valve work or you've had some sort of invasive in-heart procedure, then they might recommend it. So rheumatic heart disease is a response to group A beta hemolytic infection. So these are kids that get strep throat and their parents didn't take them to the doctor or the nurse practitioner and didn't get them antibiotics. So an untreated strep throat leads to this rheumatic heart disease in some patients. Basically that beta hemolytic strep travels into the heart area and it embeds itself into the heart valves and causes these things called Aschoff bodies, or ASCHOFF, Aschoff bodies. They develop on the heart valves and we can see them whenever we do an echo. The mitral valve is most commonly affected. This usually develops anywhere from a couple weeks to 6 weeks after strep, and that's going to be a question that you'll see in NCLEX or see getting tested. You'll be like, this child is having this, and suspecting of rheumatic heart disease. What questions should you ask them? And then you'll say, did you have a sore throat, a month ago? And that's kind of what they're looking for there. So when we're talking about signs and symptoms or manifestations, arthritis is the most common. This is going to affect the joints in kids. They're going to complain of pain. They'll have a low-grade fever. This can ultimately lead to valvular issues or stenosis because these Aschoff bodies are going to cause scar tissue on the valves and prevent them from functioning properly. So they can fuse together, they can get scar tissue and become stenotic, or they can not close properly, and that can cause regurg or blood backing up to where it came from, which is, by now, in this point in the lecture, is not a good thing. Erythema marginatum are these red spots that don't have any pus or anything in them, but they're going to be this red rash on your trunk and extremities. Chorea is very scary. It's this irregular movement which kind of looks like a seizure, and it's really involuntary, and they're really unable to stop it. It eventually does go away. And then the subcutaneous nodes, which are these like little tiny swelling spots over the bony prominences, so especially like knuckles, elbows, things like that, and a lot of swelling in the joints. So rheumatic fever has 3 phases. One is the acute phase that lasts 2 to 3 weeks, and it's characterized by the inflammation of the connective tissue in the hearts, joints, and skin. So all those signs and symptoms we just talked about. The second phase would be the proliferative phase, and that's primarily happening in the heart, and that's where those Aschoff bodies really develop and really start damaging the heart valves, the cardiac valve leaflets, and that gets the scar tissue, valvular stenosis, and the regurg or regurgitation. And then all in all, the episode of rheumatic fever can last up to 3 months. It's pretty self-limiting, which means it's not going to stay around forever, but once it's caused the damage to those leaflets, that cannot be reversed. So then long-term consequence of the rheumatic heart disease is obviously the valve damage. And then the convalescent phase is whenever you start treatment and kind of get back to where you're going and hopefully catch it before the valve damage. But anyway, difficult to diagnose. So we're going to talk about this Jones criteria. So that's what we use to diagnose it because it can mimic other diseases. So Jones criteria describes frequent symptoms of rheumatic fever, which are listed according to likelihood or rheumatic fever infections as major manifestations and minor manifestations. And then the diagnosis is based on the presence of 2 major or 1 major and 2 minor. So major are going to be the multiple joints, the carditis, the chorea, which is the movements, the rash on the trunk and body, or the subcutaneous nodes. And then the minors, the fever, the aching joints, the elevated ESR, which is an eosinophil sedimentation rate, which has to do with infection, and CRP, which is a C-reactive protein, also has to do with infection. Prolonged PR or QT interval, and that is, back into the EKG point. And the reason why we would have that is because the heart is infected and inflamed and irritated, so it's not going to deliver that sinus node to the Purkinje fiber, through the bundle of His as effectively as it would if it weren't inflamed and infected. So just to recap, you're going to either have 2 major or 1 major and 2 minor of these Jones criteria, and that is something that would be tested on to diagnose rheumatic heart disease. Also, a common question related to rheumatic heart disease is the ASO titer, the anti-streptolysin titer. It's just something that's often related. It'll be elevated if you've been exposed to the beta hemolytic strep rheumatic fever. So then we'll do an echo to look at those valves, the chest x-ray. You can get penicillin, corticosteroids for the swelling and inflammation, pain relievers, and anti-inflammatories for the swelling and inflammation of the joints, and then rest, nutrition, fluids, all that fun stuff. Kawasaki's disease is super interesting. Hopefully it's diagnosed before they become a cardiac patient, and it's just what they call mucocutaneous lymph node disease or lymph node syndrome. Before they get to us, hopefully it's just high fever and joint and skin complications. But if it's not diagnosed early enough, then they get cardiac involvement in the way of coronary artery inflammation, because one of the issues of Kawasaki's is vasculitis, which is inflammation of the tunica intima, or that inner lining of arteries and veins. And one of the most common is the coronary artery or coronary vessels that get affected. So obviously they become a cardiac patient. So like I said, it's also called mucocutaneous lymph node syndrome, and it's the leading cause of acquired heart disease in kids. So it's an unknown cause, but it generally affects young kids, mostly boys under the age of 2, although I've seen it in boys and girls of all ages. There's 3 phases of this disease: the acute phase, the subacute phase, and then the convalescent phase. So the acute phase is characterized by fever, eye hyperemia, the conjunctival hyperemia, so they get the red swollen eyes, swollen hands and feet, a rash, enlarged cervical lymph nodes. Then the subacute phase is going to be cracking lips and the desquamation of the skin on the tips of fingers, toes. So these kids will get dry, cracked lips. They're going to be having peeling fingers, which is something to look out for. And then that's when the cardiac disease happens. And then the convalescent phase is whenever we're treating them, but they still have the lingering signs of inflammation. So as far as assessment and treatment goes, there's also 3 phases. Phase 1, day 1 to 10, the fever will last longer than 5 days. It won't respond to like Tylenol or ibuprofen or anything like that. They'll get the crusted, fissured lips, the swelling of the hands, the swelling of the lymph nodes or lymphadenopathy. Then phase 2 happens, day 10, 25. The fever gets a little bit better, but we're talking an irritable kid. They're going to start the peeling of the hands and feet. The arthritis is going to start kicking in, and then we're going to start seeing the heart manifestations. And then phase 3 is day 26 to 40. Then we'll start seeing some labs like the drop in the ESR, the eosinophil sedimentation rate, and diminishing signs of illness. So it's a really, really long treatment that includes IVIG or IV immunoglobulin to help them fight this. And then also, oddly enough, aspirin, which I told you before never to give children because of the risk of Rey syndrome. But in these kids, aspirin actually helps. Lots of different reasons why. It's helpful for the coronary involvement, to prevent stroke and MI and things like that we're super concerned with. But yeah, aspirin is the way to go with this one. So they expect them to be in the hospital for several weeks with this, especially getting IVIG infusions. Just for my own personal soapbox, I don't like to get into the hyperlipidemia and hypertension. These are both very preventable diseases that are becoming very common in our young children these days because of the increase in sedentary lifestyle and playing of the video games and the fast food delivery and just poor diet and soda pop and stuff. And I'm tired of hearing parents just tell me that that's all their child will eat because I don't believe that the child was born eating McDonald's and Burger King and so on and so forth. At some point, they started feeding that to them for whatever reason, and then the child preferred it, obviously, because of all the chemicals that are in these foods. So they become addicted to these foods, and that's why we have childhood obesity, hypertension, and hyperlipidemia. So hyperlipidemia is excessive lipids in the blood, which can lead, not may lead, does lead to atherosclerosis and arteriosclerosis, which is the thickening and hardening of the arteries and vessels, which puts you at risk for stroke and all kinds of fun stuff. So identify kids at risk, and that's going to be the kids that are overweight and have a poor diet and are not being active. First treatment is the obvious one, diet and exercise, and then unfortunately if they are not compliant with that and their parents are not compliant with that, then we have to start them on medications or the statins. Something to be careful for a side effect of statins, which you should know through your adult learning, is that you want to be careful for rhabdomyolysis. So any flank pain or muscle pain is a sign that we're having a very adverse side effect of the statins. So yeah, I don't really have much to say about that. I'm pretty insensitive to it. Other considerations: heart transplant, rhythm issues, and shock. Just One thing to know about heart transplantation is that these kids will be on anti-rejection medications for life. They will never stop. So cyclosporin, tacrolimus, all kinds of medications that they will have to take every day, multiple times a day, to make sure that they do not reject their heart. So I think if you have any questions about that, it's going to be about education, psychosocial issues. Most of these families are screened. And have to get approval through psychologist through the hospital to make sure that they are going to be supportive and a good environment for the child that's getting the heart. So I don't feel like we've ever really said no to anybody, but actually we did say no to somebody. Anyhow, a lifetime of anti-rejection meds, just know that that's super important. But hearts can last a really long time. They're pretty fantastic. Rhythm issues, you should know that through your adult learning. The most common issue I think we would see in kids would either be the channelopathy with that long QT syndrome or a Wolff-Parkinson-White, WPW, and that's a irregular tachyarrhythmia where the kids just spontaneously get SVT or supraventricular tachycardia. You can look into those if you're interested. And then shock. Shock is the same in children as it is in adults, except for kids tend to compensate just a little bit longer because they're amazing. So that sums it up. I really tried to keep it short and sweet. Please let me know if you have more questions. Otherwise, good luck.